Dr. Afsana,
Yes, ma'am.
please start.
Good afternoon, everyone. Today I am going to present an interesting topic of non-seeing child sensitization to MELAS in an emergency ophthalmology setup. I do not have any financial disclosure. Just before going to my actual case, I would like to briefly introduce about the topic, that is MELAS. MELAS is mitochondrial encephalomyopathy, lactic acidosis and stroke-like episodes. It is frequently inherited mitochondrial maternal disorder which affects the tissues which has very high metabolic activity like skeletal muscles, heart, brain, kidney, eye. So it affects the various organs with variable presentation. The most common mutation is MTTL1 gene. So what happened with this mutation? This mutation will lead to decreased energy production at the mitochondrial level. That will lead to increased anaerobic glycolysis and will lead to increased lactic acid. And that increased lactic acid, depending upon the site of the tissue where it is collected, it will lead to signs and symptoms in the patient. Now coming towards our case, a 1-year-old male child presented to pediatric emergency with the abnormal body movement and fever since 2 weeks. After the stabilization of the primary complaint, the child was referred to ophthalmology department in view of poor eye contact. The child presented to us with this complaint, already undergoing treatment for the same. The development history for the child was normal before the onset of symptoms. There was normal birth history and the immunization history. Upon systemic findings, we found that the child has focal onset seizures which involve the left side of the upper limb and the lower limb. Upon central nervous system examination, we found in the motor examination the tone was variable on the left side, power was more than 3/5, reflexes were very brisk on the left hand side, suggestive of upper motor neuron lesion, and plantar reflex was also bilateral downgoing. Rest all the cardiovascular, respiratory and per abdomen examination was within normal limit. Now moving toward the investigation, we did CSF tab that was found to be acellular. In venous blood gas analysis, lactate was found to be raised, suggestive of lactic acidosis. In the MRI brain, we found the hyperintense lesions on T2 and flare with restricted diffusion, suggestive of encephalitis more than infarct. Upon ophthalmologic evaluation, we found that the child was not fixing to light, pupils were normal, extraocular movements were full, anterior segment examination was within normal limit. But when we did the posterior segment examination, we found hypopigmented lesions over the posterior pore that corroborated with the reported ophthalmologic findings in MELAS, which are observed in approximately 40 to 50% of the cases. So with the triad of presentation of encephalitis, stroke-like episodes, and lactic acidosis, along with our ophthalmic findings of pigmented retinopathy, help in diagnosis of MELAS that was later confirmed with a genetic testing, which was found to be positive for MTTL1 gene. So which was also seen from a review article of pediatric neonatology that the ophthalmic manifestations are the second most common manifestations in these mitochondrial disorders, and these has various presentations like ptosis, RP, external ophthalmoplegia, visual loss, etc. So a non-seeing children can be a diagnostic puzzle for pediatric ophthalmologists, but if we are aware about these findings, it will help the pediatric ophthalmologist and neurologist in clinching the diagnosis and starting appropriate management. So my take-home message from my case is early ophthalmic evaluation is a valuable diagnostic tool in the multidisciplinary approach to MELAS management, and ophthalmic findings should not be overlooked. As MELAS has no cure, the child has to die, but our patient died at 1.2 years of age. So if we early diagnose the patient, we can prolong the life of a patient, because the reported literature shows that this child usually dies at the age of 35 years of age. Thank you.
I think this was nice presentation, but in the title you have written MELAS. Many of the people may not know what is MELAS.
Therefore,
So you have to justify each of the very abbreviation, and may not be placed in the title, ideally.
Yes, sir.
What is MELAS?
Sir, MELAS is mitochondrial encephalomyopathy, lactic acidosis, and stroke-like episodes. It is a mitochondrial disorder, basically hampered the energy production at various parts of the tissues.
Now, how did you think about going into this aspect of this study, in this study? Just because you saw the child was blind, or how did you think about this?
Sir, actually we got a referral from pediatric department to look for visual acuity of the child. Then we did further follow-up and found in the literature and confirmed.
By pediatricians.
Sir, after
you just find the ophthalmic evaluation, that's all.
After reporting of our ophthalmic finding, they sent genetic testing for MELAS, which was found to be positive.
But how should we suspect MELAS?
No, did we suspect MELAS or did they?
They are suspecting mitochondrial disorder, sir.
And then
So
you investigated it.
we investigated.
No, they only investigated.
They.
They investigated.
That what was your role in this?
Hypopigmented patches.
I think it will be very difficult for pediatric ophthalmologist or anybody to primarily diagnose this condition because this requires
Yes, sir.
pediatric neonatologist this thing, as well as, of course, they require genetic testing. That is what is very important these days. Otherwise, they won't establish the diagnosis.
No, my this thing was how, as an ophthalmologist, I should suspect MELAS in a child. It's not possible. Na?
No, sir.
So that's what we were looking for. You
It
see,
just-
as a pediatrician, तो पूरी नेल्सन की किताब हमें आनी चाहिए वो तो that's impossible. What I'm saying is, this study would have become wiser in case our role should also increase. And एक बच्चा देखा he can't fix it. Should I suspect MELAS? No. So when should I suspect MELAS? Chal, good.
Thank you,